Good evening, and thank you for joining us for today's evening. We have a very interesting session today because we have a very expert speaker for the day. Today, on behalf of Dr. Reddy's team, I welcome you all. And today we have Dr. Vivek Agarwala, sir. Sir is a medical oncologist from Narayan Super Specialty Hospital, Kolkata, with over 11 years of experience in treating cancer patients. Sir has been part of all kind of treatment cancers and has been very successful. Apart from that, Sir is also a very kind-hearted person, and he has graciously given his time for us for today's topic, which is understanding lung cancer and how we can prevent it. So, without further ado, I'd like to welcome Dr. Vivek Agarwal, sir. Sir, thank you for joining us.
Yeah, good evening, and many thanks to Dr. Reddy for giving me this opportunity. It is always a very pleasant experience interacting with the common public and the common patients regarding any aspect of cancer. And I'm really delighted that today we are doing this, and I'm really looking forward to it today.
Thank you, sir. So, before we begin, I'd like to request all our listeners, viewers, if you have any questions, any queries, no matter how insignificant you feel, please feel free to post it. In due course, as we are discussing the disease or problem, so we'll ask, sir, and accordingly, you'll get your questions answered. So, sir, I think if we don't mind, sir, majority of people who is listening here have not understood cancer in a way. Exactly, what is a cancer? And when they hear a cancer, they think it's some kind of a disease which can spread even by touch. Sometimes they feel in, especially in the rural India. So, sir, would you be kind enough to explain exactly what is cancer?
Yeah, so that is what you said earlier that I would request all the viewers and listeners here to please come forward with any queries and questions because I would like to make this session a very interactive one. I am here to also learn about things from you, from your questions, trying to understand, and I'll be very happy if I could clear some of your doubts also. And even though this question sounds a very basic one, as what is cancer, but even at the highest scientific level, there are certain, nuances to it, and there are certain complexities to it that really make this question a really complex one. And it is not just that simple. But to make it more simple, we have to understand that in our body, we have normal cells that grow in a very orderly fashion. So, because of this ordered growth, you see, we have a specific function which is dedicated to specific organs and which is making a specific appearance. And therefore, our tissues are differentiated into different, hands, organs, everything. We are all functioning together in a perfect milieu of homeostasis because there is a very ordered manner of cell growth and cell death. Now, what happens in cancer is that some of the cells which are there, they start behaving abnormally. Then they don't realize, these cells don't realize what is their boundaries, what is their limitation, and they start to grow beyond their boundaries in a disorderly fashion. So this disorderly growth of cells is a tumor, and when these cells, these tumor, they acquire this capacity to leave their primary and to divide very rapidly in a disorderly manner, affecting the local organ as well as spreading to other parts of the body from one organ to another or from one part to another, then it is like a frank cancer. So cancer is not a single stage or a single process. It is a multiple process by which cells become cancerous. Initially, there are certain cells which start in a very pre-cancerous manner. They go to one stage where they started a bit of disorderly growth, then they turn into another type of cells which are more aggressive, and slowly they grow outgrow to become tumors, and then they go on to become fully malignant cells and a fully metastatic disease in a stage. So there is a pre-neoplastic stage, there is a neoplastic stage, and then there is an end stage, like that. And if you look at a very basic premise of cancer, so you must understand that because our body is functioning in a very orderly fashion, our cells are dividing in a very orderly fashion. This is all controlled by our genome, our the DNA, the genes, and the disorderly manner in which these cells start behaving actually happens because there is a change at the genetic level in these cells, and there is mutations that occur in these cells. Now, because of these mutations, these genetic changes which persist and then start to become resistant to our normal control, therefore this and they persist, these genetic changes. So if it is not wrong if we say that there is some abnormal genetic mutation or abnormal genetic changes which actually lead to cancer.
Sir, if I may ask, right now you sometime time back you just mentioned the word tumor. Now, most of the time, commonly we hear कि like उसको brain tumor हुआ है, उसको lung में tumor हुआ है, उसको हड्डियों में tumor हुआ है. So, sir, in a sense, does that classify as a cancer?
So again, I'm telling you, uh, if there is any cell which is growing in a disorderly fashion whereby it is suppressing the function and growth of the normal cells and going beyond its own boundary, it is a tumor, and tumor is itself a type of a cancer. So these are all cancers. Now, cancers may not always be benign, may not always be very aggressive where they are able to spread. So sometimes we call them benign tumors and we call them malignant tumors. Now, benign tumors are tumors which are locally spreading, but the malignant tumors are one which have the capacity to even spread to distant organs. But as a whole, if we take, then they are both some sort of cancers. Benign tumors are certain low grade cancers which do not spread to other organs and have a slow mode of progression, whereas malignant tumors are high grade cancers which can spread to other organs, and they divide in a fast manner which have a fast progression. But with the basic idea, both benign tumors as well as malignant tumors are some form of cancers, and there are even examples where we can clearly see that cancers have a benign stage which whereby they progress to a malignant stage in a timely fashion.
Okay, sir. I think that would be very good clarity to understand now because this is very difficult when common person hear tumor, they get very scared that it's a matter of life and death now. Sir, going ahead, in today's day and age, sir, how common are we seeing different types of cancer in India, sir, both male and female wise?
So, just before I answer this question, you clearly said that there are certain type of tumors which are very benign and which are not life-threatening, and and people or patients should not worry about them because they are never life-threatening. For example, if you talk about basal cell carcinoma of the face or the skin, so it is some sort of a very benign tumor and is usually not malignant. There are many people who have lipomas. So again, these lipomas are benign tumors and they are seldom life threatening. So the best way I which a patient can actually find out about the risk of his cancer or tumor is to visit an oncologist and get a clear idea from them. So please do not be afraid whenever you are hearing tumor or cancer, because what is the risk of progression, what is the risk to life, is something different across different cancers. If you have a meningioma of the brain, it is not a malignant tumor, it is a benign tumor. If you have lipoma, it is a benign tumor. So again, there are hundreds of types of benign tumor, and there are hundreds and thousands of types of malignant tumor. So whenever there is any confusion, please do not be afraid and visit your nearest oncologist to know the exact risk of your tumor, to understand it better. Now coming to the question that you asked is what the different types of cancers. So when you talk about different kinds of cancers, of course we will talk about the aggressive and the malignant ones, which are most life threatening to people, because we are not really worried about the benign tumors. Now coming to the malignant tumors, uh, so the in India, if we see, then there is an average 70 to 80,000 cases of new cancers being detected every year. Now, this is as per the Globocan 2018 data. And I must say that this is the official data, which is probably and most, surely underreported. So, if you talk about the exclusive number of cases, I think probably in India there are 2 lakh cases of cancers every year, and there are around similar 2 lakh deaths due to cancer every year. Coming to the different types of cancer, so in males, the most common cancers that we see in India are from the head and neck cancers of the oral cavity, the larynx, oropharynx, and the lung cancers. These are the most common cancers in male, and then cancers of prostate, of colorectal, and stomach, and these cancers, they come later on. If you talk about females, then the most common cancer is breast cancer, and breast cancer, the numbers are so high that it is the highest incidence of any case, taking both males and females together. So, breast cancer is the most common cancer in women. And apart from breast cancer, again, women also have lung cancers, colorectal cancers, stomach cancers, ovarian cancers, and cervical cancer. These are the most common cancers in women.
So, sir, as you have just mentioned, lung cancer, sir. In a sense, sir, how do we say that person has got lung cancer, and what are the commonest reason for it?
So, uh, lung cancer is, it is unfortunate that 20 to 30% of lung cancers are only detected in an early stage, whereas 70% of lung cancers are detected in an advanced stage. This is because again, lung is a organ which is inside, and smaller growths are smaller tumors are sometimes not even detected by X-rays. So that is the reason why this happens. Now, if you talk about how can we, sort of know who is more at risk of lung cancer and who is less at risk. So smoking is invariably the most common cause of lung cancer. Smoking is responsible for more than 90% cases of squamous cell carcinomas and small cell carcinomas, as well as 80% cases of adenocarcinomas. But adenocarcinomas, they do occur less due to smoking, and may occur also in non-smokers. Apart from smoking, the other risk factors do include exposure to pollutants, and there is sometimes high quantities of radon, which is exposed, which is there in industrial pollutants as well as in certain household pollutants. So this is also one of the important causes. Apart from this, other causes include exposure to other industrial substances like silica, like asbestos, like other coal. So all these can also lead to lung cancer. But the type of lung cancer that is due to asbestos silica is usually different, because it is a mesothelioma, which is a different type of a, lung cancer. So these are the common risk factors. Lung cancer is less genetically driven, so the genetic risk factor or familial risk factor due to lung cancer is less. But smoking and tobacco exposure is the most important risk factor that we have to take into account.
So
Uh,
yeah, sorry. Yeah, so you have just mentioned about smoking and use of tobacco. Uh, but on the other hand, it is also seen that a person who is in a household with a person who is smoking, that non-smoker gets lung cancer much before, while otherwise the smokers doesn't have that kind of an issue. So, sir, what is that this phenomena?
So you see, we can get such kind of anecdotal, incidences many times, where people who have been using tobacco for years don't have oral cavity cancer, whereas somebody who has not used still gets. So we must again understand that each one of us have a different susceptibility towards cancer. Everybody is genome is different. While somebody's genome may be more susceptible to damage and become cancerous, and somebody's genome might be less susceptible for damage. So there is an inherent risk towards getting cancerous, that is there with everybody. And this is something which is non-modifiable. But then there are certain other modifiable risk factors, like the environmental factors, which includes exposure to tobacco, as well as exposure to other kind of carcinogenic substances, including alcohol, including infections. For example, there are certain viral infections like HPV infection, which causes cervical cancer. There's an Epstein-Barr virus infection, which can cause nasopharyngeal cancers, Hodgkin's lymphoma. So there are certain infections. There are certain carcinogenic substances like smoking, tobacco, alcohol, like pollutants. All these together work in order to create. So somebody who has a very high susceptibility towards cancer, but is less exposed to any uh, carcinogen, may get cancer early, whereas somebody who has a very less susceptibility towards cancer, even though is exposed to high quantities of carcinogens, may not get cancer. So that is the reason why this happens, that somebody who is not smoking, even though they get cancer.
So, like as you have just explained that there's some kind of susceptibility to that. So we have seen for very long years that what rural India is exposed to, like tobacco, like hookah, bidi, much more, and urban India more of a cigarette smoking, pipe and cigar smoking. So, is there any difference in the kind of lung cancer you see in your clinical practice between these two kind of situations?
Yeah. So it's a very relevant question, that there is difference in the pattern of smoking that we see in the pattern of tobacco exposure. So we must understand that in rural India, where there is much higher use of smokeless tobacco, so there is more of a squamous cell carcinoma that happens, and that is also more commonly occurring in the the upper aerodigestive tract. So they get more of oral cavity cancers, or cancers which are there in the upper respiratory tract, for example, in the throat, in the larynx or so, as well as they get squamous cell carcinomas, which are there in the more there in the hilar regions, or there in the trachea. Whereas those patients, as I said earlier, also adenocarcinoma lung is something which is less driven due to tobacco as compared to squamous cell and small cell, and that is why we see more adenocarcinomas in our urban population, where it is more due to smoking of a cigarette and all, because they probably have a more peripheral disease in the lungs rather than a central disease in the lungs. So squamous cell carcinoma definitely we get more commonly in our rural population, and adenocarcinoma is something that we get more commonly in the urban population, in women and in non-smokers.
Sir, right now, as you told about the difference between urban and rural India, sir, one question's come into my mind because now we are seeing the more women who have started smoking. And Western culture also, they have been more exposed to smoking, like during even pregnancy, they do smoke. So, sir, how bad of the impact is on the unborn child because of this kind of smoke or secondary smoking?
So again, smoking itself, the smoke that is there, it contains multiple carcinogens. There are multiple cyanides and hydrocarbons, and there is a list of carcinogens. There are more than 60 or 70 carcinogens which are there in smoking, and all these carcinogens, they again impact on the cell by causing mutations. And if there is mutation which is there early into the life, then these mutations are more resistant, they are more strong, and they are more likely to survive and perpetuate, thereby causing cancer. So again, it increases the risk of cancer in the individual subsequently. And just as I said that there is difference in susceptibility, but the environmental factors, the modifiable factors are not just the smoking or exposure to carcinogens or infections, but also obesity, diabetes, your fitness, exercises, nutrition, they all are also important together to under to know or to sort of determine the susceptibility towards cancer.
So I think that will be very useful to our viewers and listeners. Sir, having said that, if a person has developed lung cancer, what will be the first common symptoms or signs which he or she gonna face?
Yeah. So whenever there is, sort of when we should suspect that there may be lung cancer, so we must, sort of understand that the most common symptoms that lung cancer patients present with is coughing, is the shortness of breathing, and pain in the chest. And sometimes the pain is very peculiar because it increases on deep breathing or coughing, and it may be associated with systemic features like generalized weakness, weight loss, decreased appetite, difficulty in sort of swallowing, and sometimes even change in the voice. So uh, uh, if you talk about the cough, so again, usually it is a non-productive cough, and a cough which lasts for more than 2 to 3 weeks, and which is not resolving on routine medications or routine care. So whenever you have such kind of a cough which is persisting beyond 2 to 3 weeks, especially in somebody who is a smoker or who is being exposed to smoking, even passive smoking, and who is exposed to pollutants, then you should suspect something is abnormal. And in these kind of individuals, usually the first investigation is a chest X-ray. But if there are other strong features which are suggestive of cancer, like coughing with sometimes blood coming in the cough, or increasing shortness of breathing, generalized weakness, pain in the chest, which is typically increasing on deep breathing or on coughing, and associated with other systemic features like weight loss, like generalized weakness, then you should go ahead and do a CT scan in order to confirm. Smaller lesions which are less than 1 centimeter are unlikely to be noticed in a chest X-ray, and a CT scan can pick them up early.
Uh, Sir, as you have been talking about these common symptoms like shortness of breath, coughing. So sometimes, sir, what happens in our country, because we are also a hub of tuberculosis. So some of these symptoms are also common with tuberculosis. So how should a patient proceed between these two?
Yeah. So, as very correctly said by you, that tuberculosis being a prevalent illness in our country is many a times confused with lung cancer, and not even patients. There are many peripheral physicians who have, sort of start a patient on anti-tubercular drugs, thinking that it is tuberculosis, and then these patients progress and the cancers progress and they are later diagnosed at an advanced stage of cancer. So a basic thing that we must understand is, if there is a suspicious patch in the lung, then you should do a CT scan. Doing a chest x-ray is not enough to characterize whatever patch or a nodule is there. Number two, along with that, we should also look at clearly what is the risk, susceptibility, and exposure. Now, if there is a person who is a smoker, then obviously, if it is more than 50 or 60 years of age, then the chances of lung cancer is probably higher. But if there is a definite history of exposure to somebody who has COX, then this chance of COX is higher. Again, a diagnosis of uh, pulmonary tuberculosis being made just on X-ray is a very wrong practice. You should not diagnose pulmonary tuberculosis or COX until and unless you have a sputum report which is positive for AFP, acid fast bacilli, or you have an FNAC or a biopsy whereby there is a clear cut granulomatous inflammation that is being shown. So this is happening only because in most of in the periphery, the guidelines are not being followed, and just on the basis of radiological picture, patients have been started on anti-tubercular drugs. Otherwise the guidelines are very clear, and the appearance of a cancer and the appearance of pulmonary tuberculosis are really different, because a tubercular lesion is will be having some sort of a consolidation or a pleural effusion, but a cancerous lesion will definitely be seen as a lesion which is not confined to a particular segment of lung or the or a lobe of lung. It will be seen that it is going beyond to other segments and other lobes, which is something very rare in tuberculosis. Again, tuberculosis patients will have definite history of low grade fever and weight loss, these features. But although I agree that these are also present in lung cancer, but if you do a sputum examination and a CT scan and a proper biopsy, then I don't think that you would miss a lung cancer lesion or misdiagnose it as tuberculosis.
Sir, in the start of your talk, you also explained that some bacterial or viral factors could also lead to different types of cancer. So, sir, how does that statement hold true for the tuberculosis disease progressing to lung cancer?
So tubercular disease doesn't spread to doesn't go ahead to lung cancer. It is a different pathology with different it is an infection, and lung cancer is different, and tuberculosis is different.
Okay, sir. Sir, as we are in the COVID world, sir, so how does that COVID problem has impacted the lung cancer patients, sir, in your practice?
So again, there has been also some delay in diagnosis, some sort of delay in presentation, because patients are not presenting them early due to fearing the COVID. Again, there are patients who are having some respiratory illness, but again they think that probably it is COVID, so that is why they are again avoiding visiting. So there is some sort of an overlap. And again, if I say that if our lung cancer patients, if they are having COVID infection, they are more susceptible to having severe illness, because they are already having compromised lung function. and top of that, if they get COVID pneumonitis, then for there's further deterioration of lung cancer. So COVID is not good for any cancer patient, and lung cancer patient again definitely not good. And it has definitely affected the survival of our lung cancer patients, delayed the diagnosis and delayed treatment also for many of our patients.
So, as you have just talked about the delayed diagnosis and delayed treatment, sir. So, how does the treatment in today's day and age has impacted the overall survivability of lung cancer patients?
Yeah, so there is a very remarkable and epoch-making change in our approach towards lung cancers over the last 2 decades. Now, 2 decades ago, if there is a patient of advanced lung cancer, usually what everybody would be think is maximum to maximum survival of 1 year or less than 1 year, and there were just few chemotherapeutic drugs by which we were treating lung cancer. But in the last 2 decades, our understanding of lung cancer has changed in a very, very remarkable way, in such a manner that in today's age, we have understood that a person who has lung cancer is, the lung cancer of one person is so different from a lung cancer of just another person. And that is how we have advanced to what is called personalized medicine or precision medicine in and lung cancer is the most beautiful example of it. Now, before I elaborate on the current treatment way of lung cancer, especially in the advanced stages, because that is what 80% of our patients are, we must understand that previously lung cancer was not so well defined, but now we clearly know that lung cancer is of different types like adenocarcinoma, squamous cell carcinoma, small cell carcinoma, which are the main three types. And again, even in the squamous or in the adenocarcinoma, we are having now multiple molecular targets which are defined as the driver mutations of these lung cancers. So the biopsy is being tested nowadays for multiple molecular targets and mutations. There are different kinds of mutations that have been observed, like the EGFR mutation, ALK mutation, ROS1, MET, BRAF, RET, NTRK, HER2, and there are so many mutations which are being targetable. So in the and then we have nowadays the immunotherapy coming up in lung cancer. So we also have to see whether these cancers express PDL1 or not, which are again markers for efficacy of immunotherapy. So, if in today's age, if I have a patient of adenocarcinoma lung, a patient who is EGFR positive is treated differently, ALK positive is treated differently, ROS is treated differently, MET is treated differently, RET is treated differently, HER2 positive is treated differently, BRAF positive is treated differently, and so on and so forth, so that PDL1 positive is treated differently, no mutation positive it is treated differently. So if you look at such kind of a personalized treatment, so more than 50% of adenocarcinoma patients are going to have some sort of a targetable mutation. And although the percentage of targetable mutation is less in squamous cell carcinoma, but there also almost 10 to 15% will be having some sort of a target. And in small cells, definitely the target is less, but here also immunotherapy has now come into the first line. So much so far that nowadays the overall survival, median overall survival of lung cancer has definitely improved. If you take the whole bunch together, it is definitely more than 2 years now. But if you look at median survival of EGFR positive lung cancer, that is beyond 5 years. If you look at the median overall survival of ALK positive lung cancer, it is even reached 7 to 8 years. And if you look at PDL1 positive patients, there also the median OS has increased to more than 3.5 years if they are treated with immunotherapy. So the survivals have definitely improved over the last few years, and more so in the patients who are having the good prognostic type of disease where the molecular markers are positive.
So, sir, how early should a patient get diagnosed to have any kind of better prognostic? So is there any time-bound treatment or anything?
Yeah, so just as I said, the 30% of our patient, 20 to 30% do present in an early stage. And in the earliest stage of lung cancer, when there is a small tumor only without nodes being involved in the mediastinum, then these patients are also definitely curable by upfront surgery that can be done, or an upfront chemoradiation that can be given. And even in a locally advanced setting, also chemoradiation can be given. And with surgery and chemoradiation, the median overall survival is nearly, sort of 2.5 to 3 years, and the 5 year overall survival is more close to 40 to 45%. So what we can say is 40 to 45% of early stage and locally advanced stage can be cured of lung cancer if they are presenting in an early stage of disease, or what we call as stage 2 or stage 3. But in stage 4, when it is an advanced stage of disease, then we talk about the advanced stage treatment in the form of targetable treatment or chemotherapy or immunotherapy.
Sir, right now, as you have explained about the surgical and the chemo radiation part, sir, most of the time our listeners and common person are worried because of the quality of life post surgery and chemo radiation, because be it a movie or be it a old age, matlab seniors telling their youngers that this is a very bad situation, your life will become hell. So, what do you want to tell those people who are worried because of surgery and chemo radiation on the quality of life?
Yeah, so lung surgeries are not easy, and lung surgeries are definitely demanding. But there is some sort of a pre surgical conditioning of the patient, whereby with physiotherapy and with pulmonary exercises, we tend to improve their pulmonary functions. And with the modern medicine and modern evaluation techniques, as well as post operative rehabilitation, the complications have definitely decreased over the years, and quality of life has improved. Even in chemo radiation, because of IMRT techniques, nowadays the area of lung which undergoes radiation is reduced to the minimum, so that the toxicities are minimum. And oncologists and oncology centers do take rehabilitation in a very serious way, physiotherapy in a very serious way, nutritional assessment, and promotion in a serious way, which has improved the outcomes over the years. So definitely patient selection is a key. Not all patients who are feasible for surgery would be going ahead with surgery, because some of them may not be fit for surgery, but we definitely do the fitness evaluation, and only the fit patients are taken for surgery as well as for chemo radiation. And in those fit patients, definitely more than 80 to 90% patients we are able to rehabilitate well.
Uh, Sir, most of the, at least in Indian medicine, sir, the belief of India is quite high. So they believe in like in alternative medicine like Ayurveda and homeopathy. So do you find any kind of impact of these kind of traditional medicines, especially in the patient you're seeing on the lung cancer?
Yeah, so it's not just about lung cancer. I think in all cancers, there are patients who take alternative medicine, or traditional medicines, and do not take. But I think in modern day, what we actually all believe in evidence-based treatment. So if there is an evidence for some sort of traditional medicine or alternative medicine, even I would be very happy to use it. But we all follow evidence based medicine, and I think that is what I tell all my patients, that you should always do or take treatment which is evidence based. and most of the times you don't have any credible evidence for alternative medicines. So there are so many times we have patients who have progressed or lost because they have not taken treatment timely. And cancer treatment is all about diagnosing at the right time and treating at the right time. So I think evidence-based medicine is what everybody should practice. Talking about patients as well as doctors as well as everybody, we should look at the evidence. And alternative medicine, they don't have any credible evidence that they work.
I think, sir, with your thoughts and the messages, the most of our audience are quite satisfied. Sir, we are coming to the end of the program. So, in the end, sir, what will you suggest to all those patients who are suffering from lung cancer on one hand, and to those people who can be saved from developing these kind of diseases?
So I think I'm very clear in my message, and today's conversation also, that smoking is the most important risk factor, and we have to have anti-smoking campaigns and anti-smoking laws being coming in to save our patients from getting lung cancer. Because the only if there is increased smoking exposure, which is the the most common cause of lung cancers, then I think we should have a very strong measures to decrease the smoking rates in our population. And that is what I will tell everybody, that please avoid smoking. You have to stop smoking. If you are not stopped yet, you please remember that if you are smoking, you are not only putting yourself at risk, but you're also putting your family members and other people also at risk, who are getting exposed to your smoke indirectly. And uh, if you are stopping smoking, not only will decrease your chances of lung cancers and oral cancers and esophageal cancers and bladder cancers, but it also decreases the chances of atherosclerosis, heart diseases, and also, so smoking is a major killer. And I would say that if you want to avoid disease, you should stay away from smoking. And if you have any symptoms, that I say, that if a chronic cough which is not going on a routine treatment, or increasing shortness of breathing, chest pain, then please consult your nearest oncologist. Go ahead with a CT scan. Once if you are diagnosed with a lung cancer, please do not worry. Yes, initial evaluation does take some time and expenditure, but it is totally worth it. There are so many patients who are they fear the, or they don't comply with the investigations, or they complain about the initial expenditure of investigation. But an initial PET CT scan and the molecular tests, they are the cornerstone of treatment. And sometimes there are so many cases where molecular investigations do lead to diagnosis of an EGFR positive, where even simple oral drugs work better than costly intravenous medications. So as per the oncologist advice, do go ahead with a scan, do go ahead with biopsies instead of FNAC, and do go ahead with molecular investigations for the earliest diagnosis and proper treatment.
Uh, Thank you, Dr. Vivek Agarwal, sir, for your valuable time, and I hope our listeners are quite benefited from your talk, and they can be able to fight from this disease. Thanks a lot, sir, for your time.
Yeah, all pleasure. It was all my pleasure. Thank you, and good evening, everybody.
Thanks, sir.